We will share it on Workplace, or if you'd like to get it, you're welcome to email me. We will have your lines muted until the end of the presentation, where we will unmute them and hope you'll comment. But also, please feel free to enter questions into the chat box throughout the presentation. Dr. Lisa Letourneau, our physician consultant for the Choosing Wisely Learning Network, will be moderating the session, so I'm going to turn it over to her to kick off the webinar.
Super. Well, thank you, Kelly, and thanks so much, everybody, for joining us. We're really excited to have some great presenters here today. I think, Kelly, you're advancing the slide. Yes? So I'm pleased to introduce, we have two speakers today. First is Dr. Greg Blommel. Greg is with the Wisconsin Collaborative for Healthcare Quality, or WCHQ, as it's known, where he came to the organization after serving as chair of the board for the organization and currently serves as medical director. He brings a lot of leadership experience, having served as chair of the Measurement Advisory Committee and vice chair and chair of the board of directors previously. In addition to working with WCHQ, he serves as medical director of quality and outcomes for Froedtert and the Medical College of Wisconsin community physicians and leads their Choosing Wisely initiatives there. He also maintains an active clinical practice, so he is a busy guy. He's been very involved with clinical measurement for much of his leadership career and has designed incentive programs, including payer and provider organizations. He's received his medical degree from the Medical College of Wisconsin and is a board-certified internist. Additionally, we have Dr. Gabrielle Rude, who's the Director of Practice Transformation for WCHQ, and she works with that organization, which is a nonprofit voluntary consortium that works to improve cost and quality in Wisconsin through public reporting and comparative performance. She has a PhD in population science from the University of Wisconsin, is a certified professional in healthcare quality, and serves on the board of the Wisconsin Community Health Fund and Green County Leaders at the University of Wisconsin Extension, as well as the Advisory Council for the University of Wisconsin's Institute for Translational Research. She's passionate about assisting healthcare providers and has also done extensive work on the Choosing Wisely initiative in Wisconsin. So thank you so much, Greg and Gabriel, and we'll be looking to the two of you.
Great. Thanks, Lisa. Well, thank you for having us. We're happy to be here to talk about our work. So this is Gabrielle Rude. So I will start out with our presentation before I turn it over to Greg to really talk about the application of some of our data to improve through our Choosing Wisely campaign. So the objective of what we want to talk about this morning is to show how you can use data to improve, to achieve improvement in overutilization. So we're going to talk about improvement strategies and how they're different when you are focusing on over versus underutilization. We're going to show different measures that are needed depending on your focus area. So whether you're talking about system level improvement versus clinical or clinician level improvement. And then also Greg will provide some specific strategies to improve clinician level performance. So as Lisa just mentioned, I work for the Wisconsin Collaborative for Healthcare Quality, and Greg is our part-time medical director. He has worked with us for many years in many capacities as a member organization, most recently serving as the chair of our board of directors, and so is very familiar with our work, and we're happy to partner with him. So WCHQ has been around since 2003. We were founded with a mission to improve quality and affordability of healthcare through collaboration and public reporting. And we do this work in partnership with various stakeholders, such as the ABIM Foundation and our Choosing Wisely work, but also many business partners and the broader healthcare quality community.
Gabrielle, I hate to interrupt you, but we can't see your slides yet.
Oh, I'm so sorry. That's strange. Okay, well, they were awesome.
Yeah, they were nice. Nice slides.
And I was advancing them beautifully, Kelly.
I believe you, which is why I wanted everyone to share in the beauty. Great, we see it now. Thank you.
Thanks for letting me know. Okay, so I already talked about what our presentation objectives were, and I started talking about who WCHQ is. So WCHQ is a membership organization. Our members are required to be able to submit data to our organization so that we can publicly report on quality. And currently our members consist of health systems, medical groups, hospitals, and most recently we've added some dental practices to our organization. Our organization is a not-for-profit that is governed by a board of directors, primarily made up of our member organizations, but we also have payers and purchasers that serve as voting members of our board of directors. And as I mentioned, we work with a variety of stakeholders. We use the term collaborative purposefully in that we collaborate with a variety of local, regional, and national collaborators listed here on your screen. So for those of you more familiar with Wisconsin, this is a list of our member organizations. We do have all of the larger health systems within Wisconsin. We represent at least 65% of all Wisconsin physicians. It's sometimes difficult to count because our data is patient-centric and patients move between clinicians. So there's some technical reasons why it's hard for us to count. We're primarily just missing the very small rural healthcare providers as well as some specialists, but we have the vast majority of primary care providers in Wisconsin. And through doing that, we estimate that we have a significant portion of actual patients, probably upwards of 85 or 90% of actual patients in Wisconsin. But this is a list of our current members. Our number of members has fluctuated with mergers, but we have continually added coverage in Wisconsin. And we cross some of our state borders as well as our member organizations do as well. So our data is publicly reported. We were one of the first in the nation to really move into this endeavor. Our data is available at WCHQ.org. And at that website, you can find all of our clinical quality measures reported both at the system level as well as the clinic level, or really the location level. Our members, they submit raw patient data to us through global files of patient demographics, encounters, and clinical data. It's important to emphasize that our data is not just billing based, it's actually harvested directly from the electronic health records. And we're able to get the information from any EHR. So we describe ourselves as being EHR agnostic in that we provide a format that we want the data to be exported into. So for those non-techie people, it looks a lot like an Excel file. That's what our members are exporting their data into, and then we can import that into our central repository. That makes us pretty unique in our capabilities to build new measures, such as those that Greg will talk about in our Choosing Wisely work, that we're able to program measures for our members. So we use a centrally programmed repository, which takes the measurement burden off our members because they submit data once, and then we can program a lot of measures off that data. As I mentioned, we have public data at the system and the clinic level, but our members also run reports much more frequently, as well as down to the patient level. They can run reports at the physician and the patient level, and the vast majority of our members do. We publicly report twice a year, but our members are uploading data more frequently, typically monthly, and can use the data for their internal quality improvement by doing that. This is a graphic for those of you that like graphics to show how we get our data. So we have a centralized repository. We call it RBS. Is the name of our repository. That is where all of our data sits. But health systems provide the data into RBS. And then we use that centralized repository to program measures such as those that are publicly reported over on the right. We also report externally to a variety of entities. We have a couple listed here. The Compass Practice Transformation Network. We are a member of a Practice Transformation Network funded by CMS. We also are partners in a program to submit data to the MIPS program, which is also a CMS incentive program, so our data can be used in that way. Our measures, if you haven't already gone to check them out at our website, but our measures, we typically like to use measures that are nationally endorsed. We don't like to reinvent the wheel if we can avoid it. But we do sometimes have to create measures from scratch when there is an improvement reason and our members feel we need a new measure. We have created measures from scratch. We utilize our Measurement Advisory Committee to oversee this work, which is primarily a physician-led committee within our organization. So our members selection is driven by what our members want. We make sure that it's clinically relevant. That's why we have physicians running that committee. We do look at the availability of data and the burden of measurement. Our data, it can be a burden if you're pulling too much data, so we're very cognizant of that limitation. And then we work with experts to make sure we're measuring the right thing and that we're going to have a meaningful impact of what we measure. So here's what we have publicly currently. We do have more measures available behind the scenes that our members are looking at. Sometimes our measures start out behind the scenes and then they go into the public realm. Other times we just have measures that we choose not to publicly report for a variety of reasons. But this is what you can find if you go to WCHQ.org. You'll see that most of our measures are in the primary care space. We're actively working currently, though, to move into specialty care. So more measures in that space will be coming. But really, it's a remnant of how we started as a primary care-focused organization, but more will be coming. Should point out also that because we pull data from the medical record, we're able not to just get whether or not a test was performed, but actual test results. So we can tell if diabetes is controlled, as an example, and that is what we publicly report when possible. So at this point, I'm going to turn it over to Greg, who's going to talk to you about how we use this really robust data to generate some incredible improvement.
Thanks, Gabrielle. And Lisa, thanks for the nice introduction. About 12 years ago, I was president of our medical practice in West Bend, having a presentation to the board. Got into a really interesting conversation with our board chair and some of the other board members who said, you know, you can't measure quality. You know it when you see it, but you know, you can't measure it. And then we failed to secure a contract with a forward-leaning employer representative, and they got a lot more interested. And now maybe we can measure quality. And so it's been an interesting journey the last 12 years. Now as the medical director with WCHQ, that's what we do, is we improve outcomes in quality for our members. So here's a definition: the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes that are consistent with the current professional knowledge. Very operational. I like that definition. But I'd like to point out, and it's relevant for this conversation, it's really two sides to that. There are things that should be done that we're not consistently doing, and we call those the underutilized measures. And then there are measures that are being that we're looking at on conditions and treatments and testing that are potentially harmful and that we shouldn't be doing. And that kind of outlines really sort of the approach in quality that I've been involved with for the last few years. Now, as Lisa described, I'm an active I have an active clinical practice about 75% of the time, and I work at Freighter at the Medical College. We have it's an academic and clinical partnership, multiple locations, at least it's probably closer to 30, over 1,000 academic physicians, just to kind of give you an idea, 3 inpatient locations. So we gave a slide, we showed some of the measures. I'm going to just highlight a few of them here that are representative. Diabetes A1C testing, immunizations, cancer screening, depression screening. And if you look at those measures, these are all measures of underuse. Arguably, each of these are attributes. They are clinically appropriate. There's positive patient perception on these. They can be tracked with a registry. Don't necessarily rely on a physician to see improvement. And much of the work can be accomplished by staff that's appropriately trained. Services are covered by insurance. So think about what's the most important of those measures when we think about these attributes. I'm not sure that I'm going to give you an answer, but I am going to show you how AHRQ would view drivers of success in chronic care. And I like driver diagrams. I'm going to take a minute and do a shout out to Charlene Ramey, who I worked with extensively on the study that we are really highlighting today. This, by the way, is a 34-month Choosing Wisely study that went from May of 2016 to March of 18. But drivers of success in chronic care arguably rely on a registry, planned care, planned visits, standard processes, self-management, support. You don't really see the physician as a key driver in the success of those chronic care measures. Now, my kids would say, that this is really an attempt at dad humor, but I'm basically saying here that overuse and underuse, do you use the same approach? I'm a swimmer. I have swimming suit, a cap, goggles. But if I'm going to go out for a jog in the winter, I kind of use a different approach. So this whole thing is meant to be dad humor. So let's talk about underuse and overuse for a minute. We highlighted underuse already, registry-enabled, staff-assisted workflows. You can close those gaps outside of the visit. There's economic alignment. And here's an interesting idea of conspicuous care. I don't know if you've heard of the book, The Elephant in the Brain, kind of a fun read. But there's a chapter on healthcare, and it talks about this idea that that in our culture, care and providing care actually requires that you do something. So that in an overuse scenario where you're trying to reduce overuse, this might be a consideration. So just looking at overuse, there really isn't an easy registry that you can use. You can't just delegate this to staff. You really have one shot at it. There's economic non-alignment. And I just wanted to mention, and I'll mention this later, that when we asked our surveys around antibiotics in bronchitis, which is one of the topics here, 50% said they had gotten a negative survey because they didn't prescribe an antibiotic when that was what the patient came in specifically for, even though it wasn't indicated. So we're up against some very different kinds of things than the underuse scenario. And it's very much focused on the provider with some other elements of patient expectations. We talk about overuse, there's overdiagnosis and over-treatment related. There's some overlapping areas there. All of this, when we start thinking about how do you change that, the question of what are the interventions that you can use, some of which really can benefit from good data to change those outcomes in overuse. So this is a slide Dr. Lisa Simpson presented at our last collaborative learning event, and just summarizes one American Journal of Managed Care article that came out a couple of years ago that did a nice review of interventions. There's 14 different review articles that were summarized here. But the interventions for physician change really falls into these categories: academic detailing, audit and feedback, where you're giving individual physicians, in usually small group discussions, their data and having an opportunity to talk about it. CME, decision support, there's some economic incentives that are often used, local opinion leaders, multifaceted combined approach, just printed educational materials, just an email, things like that, and reminders. So those are some of the interventions. The conclusions of this particular article is that multifaceted interventions are probably the most effective, followed by audit and feedback. Passive dissemination of printed educational materials, emails, etc., probably don't do much of it at all. So when we looked at our Choosing Wisely grant, which looked at 4 different topics, and we'll talk about that here in a second, and trying to reduce overutilization, we really boiled it down to 4 major interventions. One is the provider education, where we thought audit and feedback needed to be part of that in these small group discussions. And we needed to provide physicians their individual data. Patient education, which we thought was going to be helpful in really as a way of avoiding some of those negative feedback surveys. We thought let's really work on some tools to make it easy to get through your day, to make it faster, easier to do the right thing. And then in some cases, in one case, strategic incentives, actually financial incentives, were able to be used. So the goal in all of this, again, is to change or affect the behavior of a provider at a decisional moment, emphasizing that there's no opportunity to go back later. Now, this wasn't that obvious when we started the whole grant. This became very obvious as we progressed. But yet our approach was really about giving good data and information to the docs. So we wanted to provide that meaningful information, show the variation, identify that specific behavior, and then try to make it easy. Basically, try to keep it simple. Here's the 4 topics. Antibiotics and acute bronchitis. We'll really focus on that area. It provided some great learnings. And we had a really great experience and a lot of learnings with imaging, or not doing imaging in lower back pain. But for purposes of the presentation today, we're just going to mention that. We also looked at overutilization in headaches and inpatient blood utilization. But again, for today, we're going to really focus on antibiotics. So acute bronchitis is viral, just about all the time, maybe 5%, maybe less, probably quite a bit less, will it be another item or another bacterial infection. But yet antibiotics are prescribed 2/3 of the time, leading to unnecessary visits, testing, a antibiotic resistance, adverse drug events. When we actually studied this early on in this measurement period, we realized that we were no different than this national data at the Frederick Medical College, and that 3/4 of the time, about 72% of the time, we prescribed azithromycin, which when we looked at our antibiograms, there was about a 58% sensitivity to pneumococcus, and we really needed to cover that bug. So that was a big part of what we were able to, or wanting to be able to change. So we had information, data similar to this that we then were able to provide to the individual physicians. And as we started the data collection, we were using an NQF MIPS measure on acute bronchitis, and we thought, we were really happy that WCHQ could help us collect that information. Started to run it monthly and down to the physician level. And then I mentioned Charlene, she pointed out, hey, look, we don't have any data on half these docs. And yet that was the whole point of what we were trying to do, is sit down with them and talk about their own individual performance, their variation, and be able to really engage them. So with Charlene's help, we really did a deep dive. We realized that this NQF measure for acute bronchitis relies on these J20 codes, and that our doctors were using J40 and non-specific, which is non-specific acute or chronic bronchitis, which happened to be the first bronchitis code that comes up when you in EPIC when you want to use bronchitis as your diagnosis. So it's no surprise that that was used number one. The second most common was cough, nonspecific. So we were missing a ton of data. And with that knowledge, we started to think, well, maybe we can bring in meaningful viral respiratory data into our denominator by including all of the viral respiratory infection codes, not just bronchitis, but URI and laryngitis, and have much more robust conversations. And that, in fact, is what we did. We bought shamelessly from Washington State to be able to do that. And with their help, we were able to, and WCHQ's help, we were able to then run these reports. So that was really, a critical thing for us to be able to identify that we weren't able to use that national code in those individual discussions. We were then able to sit down in small groups, have these conversations with that data now in hand, offer continuing medical education. They got CME credit for that, and about 20 physicians enrolled in a MOC program that we were able to provide, an improvement program. We are able to give them system, clinic, and provider level performance, just to kind of describe the full breadth of what we were trying to accomplish. Now, this is what we gave them. It's blanked out in terms of the physician, but at each site we gave them unblinded data that combined them to their partners at that site, showing their prescribing rates for antibiotics in that viral respiratory denominator. And we gave this information at the beginning of the conversations, which was almost distracting. They looked at that immediately, started to try to figure it out, really got them engaged. We thought that was an important part of our approach, and it turns out it really was. We really tried to focus on making sure we were keeping a broader perspective. This isn't just about not doing something. You want to assess these patients clinically. So we really, in the CME portion of this thing, talked about bronchitis and the etiology and what you needed to rule out. We try to give some algorithms and pearls, the Heckerling criteria for when you don't need to order a chest X-ray. We provided information for each of the sites that they could put as far as posters in the waiting area or actually in the exam rooms. And in many of the practices, we made it voluntary, but they utilized these. And and we'll show a little bit later that it was, in those areas where they made heavy use of these materials, it was a added benefit. Those sites did significantly better. Patient education materials, these were all made available and distributed. And then we spent quite a bit of time. I don't know how many of you worked on projects, improvement projects, where you start and you focus on making tools in Epic. It seems like every time I've worked on something, we spend time creating a smart set or a smart text. And we did that here too. Links to the guidelines, smart text, make it easy, just a few clicks if it was normal. Patient education for the after visit summary. And we found the providers that use these smart texts on a regular basis were, at the time that we evaluated this, were nearly half the prescribing rate. We're very engaged. You okay there? Yeah. Okay. But yet it was such a small number of over 300 physicians that we were tracking. Probably 30 to 40 were using the smart set, and that really isn't unusual in our experience. This is the slide that shows a comparison between the bronchitis and the upper respiratory measure. And when I say the upper respiratory measure, again, that combines all of the viral respiratory diagnoses. It correlated, very, very nicely at the system level. We started showing some improvement. But what was really interesting to this, and what was interesting to our providers, is the amount of variation that continued, despite having, gone and literally talked to every single physician at every single site. We could not budge some of these sites in terms of their performance being, literally close to, if you look on the left and the bottom, 88% prescribing rates for this diagnosis, and we had gone there twice. So that's a fascinating thing for me. That's why I started to look into the, what are some of the other drivers of this? We're approaching this from, data and sharing of good practices, but there's a lot of cultural components. There's a cultural component to this. So these two slides, 2016, 2017, still showing a lot of variation, but some overall average improvement. This is at the individual physician level. Now we just kind of descending rank on this, but they group around sites. So you don't have somebody who's prescribing at 10%, generally speaking, practicing next to somebody who's prescribing at 80% for this particular. So that kind of information, that sort of data, really created opportunity for continued discussion, digging down into it. What's happening at your site? And Charlene and I, when we worked on this, decided we needed to ask some more information to the docs and put together a survey to try to get a little closer idea of what's driving this variation. Now, I did mention azithromycin was an area of focus for us because of the resistance that has already been there, or that we've already talked about. And as the calendar year 2015, 2016, and 2017 progressed, we saw that the number of visits in primary care in our organization increased significantly. We're in a real growth period from 78,000 to 100,000. But the prescribing rate for azithromycin decreased dramatically. So we were really happy that message was getting out there. Now, I mentioned the survey, and this is just some of the responses. This is a several-page survey, and we really dug down deep in trying to find out, some of the other drivers of the variation. But 100% of the time, the doctors considered antibiotic prescribing as important. This was an important topic. They weren't just blowing it off. 73% said this data was either important or very important. What I mean is their individual provider data. So we felt pretty validated there. Yet when we gave them links to get to their data on the SharePoint site that they could have free access to, well, the vast majority didn't take the time to do that, or forgot how to do it, or just simply didn't. Preference was just put that in front of them. They're busy. They got other things to do. I understand that, believe me. Just interesting, we talk about data that's blinded versus not blinded, and does public, display of that information, what's the viewpoint on that? Well, half the physicians said, it's okay, you can unblind it. I don't mind you putting that, making it available to my colleagues, et cetera, et cetera. But half the physicians didn't want it unblinded. I guess that would be no big surprise, but we asked them about that. Providers in general had a positive view of the patient education materials, and they actually ranked that as more important than us going around and talking to them about this issue. And it sort of underscores, I think, the cultural relevance and context that there are clinics where the doctors said people just have been coming in and having this pattern for years of coming in for an antibiotic. The new docs, they might start off practicing one way, but they end up, practicing similar to the others at that site. Sites that promoted patient education materials had a lower prescribing rate than those who didn't. And I mentioned this last bullet point, the number of complaints. So in the end, when we looked at the 34-month period, we saw about a 50% reduction overall in prescribing. But I would say that there was variation in even that number. We had some locations that we went to 3 times because they were part of a maintenance and certification program, and we worked, really hard with, with that program. There were others that, we only touched. Most of them we touched twice, but there were some that were new clinics that we only got to once. But overall, we were pleased with the improvement. The ones that did the best, it was the ones that used their educational materials and that actually were engaged with some of the EMR materials. We had other areas that we worked on, as I mentioned, imaging and low back pain and imaging and headaches. We also had some success with inpatient blood transfusions. But the approaches there, that's another conversation. It was similar in the sense that we used physician education, but we highlighted in, for example, imaging, the tools in Epic, and specifically hard stops to ask the physicians, before you order this, make sure that you're creating a justification that you can document. But from the antibiotic reduction, a couple of just key takeaways that we learned. The acute bronchitis metric, while it was very useful at a system level, broke down at the clinic level, and that using this overall URI method was our way to adapt to that challenge, and it was effective. And that provider level data to engage the physicians in this seemed to be quite effective. Multifaceted approach, similar to what the study that I showed, was most effective in our data. And so, summary overall, that when we started this grant period with overuse, it really wasn't that obvious to us. We suspected it, but it wasn't that obvious that we're dealing with something very different than underuse and things that staff-assisted workflows and registries and standard work, that those were the tools that we were using for those conditions, that those don't really apply across the board. But meaningful data in this case really focused on the physician at that decisional moment was really beneficial. Variation was amazing. We still haven't figured out all of that variation, but it was very helpful for physicians to understand and engage them in a conversation. And really understand this and being able to communicate the specific behavior that we want to change to lead to the improved outcome. And certainly offering to help and make changes, make it easier to change was part of what we endeavored to do. So I think that summarizes the antibiotic experience that we had.
Terrific. Well, thanks so much. That was a great presentation, and you guys really have clearly done a tremendous amount of work, both in terms of quality reporting for years now, and now being able to leverage that into choosing wisely activity. So thank you so much for both your leadership and your work and for sharing that with us. We do have several questions in the chat, so I will start with some of those and would just encourage any of our many participants to go ahead and use the chat function as well. So the first is, did you happen to track outcomes data to coincide with the data indicating the rate at which physicians followed the guidelines?
Yeah, we talked about the data that we were collecting was, in the end, really either the physician survey or the data that we just described that we were submitting with WCHQ. We recognized that in this improvement effort, we had so many areas that we wanted to explore, but we didn't. This is one of those that we would say that we weren't able to give an answer to that.
Okay. And then from Anika Nelson, do any of the measures you used use claims data, or is it all from your EMR, or from their EMRs?
Yeah, this used our coding, our ICD codes, but it did not use claims. It was not claims-based. So it's, as Gabrielle describes our submission process, it comes directly from our EMR.
I guess by extension, I would ask, and I think we've seen others, certainly on the group, use claims data for this in terms of at least some of the areas of focus you were talking about, right, with antibiotics?
Yeah.
Right, so our data would use the billing codes. We would pull that when it was a code that would be appropriate, but it's coming from the provider, so it's coming from the provider organization rather than the paying organization. So it would be pretty analogous if you had a claim for the prescription of an antibiotic, but this would capture the physician's behavior, whether or not the patient filled the prescription. We would know that it was whether or not they were prescribing the antibiotic. There's limitations to both ends of the data, but this repository allows us to get into results in a way that you can't just from claim.
Yeah, that's pretty amazing. I'm just curious, how many years did it take for you to build the agreement? I mean, it's so unusual, right? I mean, maybe Minnesota does that as well, but very few places have a statewide repository of clinical data like that. How many years did it take to build that? I'm just curious.
Well, we started publicly reporting our first intermediary outcome measure in 2004, which was about a year after WCHQ started. So I think publicly reporting data was an immediate plan from the start, which I wasn't here at that time, but it was an immediate plan. The actual repository itself came into place, I think, in 2008, 2009 time period. So prior to that, members were needing to write the measure specifications themselves and submit numerator denominator results and then be validated. But the centralized repository was something that WCHQ realized would be really valuable so that we could centrally program measures. And this project is a great example of that, in that the teams working on it were interested in a measure. As you saw on some of Greg's slides, there were two organizations really that were working on it. His organization, Prater, as well as Monroe Clinic, their results were embedded in there. But they were the two that really wanted to work on it. But our capability allowed us to build measures and give them results without them having to submit additional data. So that is the main reason we switched to a centralized repository, was for measure burden reduction as well as flexibility in adding new measures when we wanted to.
Great, thank you. Actually, we've got a couple questions here. I'm just going to go to one that's a little bit related to that, and then I'm going to go back to some of the others. But from Bill Adams, can you talk about physician satisfaction or clinician satisfaction among those who are using Choosing Wisely? Has it been measured? Do you have a sense? Is it helping?
We are studying that actually still. One of our concerns, I'm not sure of concerns. One of the questions was, can you correlate physician satisfaction or physician burnout with performance or improvement or lack of improvement? And we're actually, still looking at that right now, and I really don't have any preliminary on that, but it's an area that we're actively continuing to study, actually.
Great, thank you. Then we also have from Josh Strait, where do you plan to go from here? What are your next phases of analysis?
Well, because this was part of a grant, and the idea was to support that grant robustly in that 34-month period. We actually have not gone back to the practices to continue to really press that issue, but we continue to collect data. So what I would like to be able to do is show the organization's leaders that when we continue to make this top of mind, that we were able to make substantial progress. And here's where we are without that continuing pressure, because the last year we're collecting data, but we haven't gone around. What we've really tried to do is move this over into the antibiotic stewardship arena. And there's certainly interest, but not necessarily the bandwidth to do what we did.
I would just add to that, though, that as a collaborative, this has been a positive experience for our membership. It's gotten a lot of visibility through Greg's work of bringing it to our members, and it's complementing our focus at this point on adding a cost component to our measurement as a whole. That's actually a large strategic initiative for us, is looking at the affordability of care, which overutilization is definitely a driver that we feel as a provider-centric organization we can tackle. So as a whole, we have a major initiative in place to focus on that topic, not specific to any of the clinical areas shared today, but we're planning on using our repository to bring in measures of utilization in different ways. The current topic we're focused on is patients with multiple morbidities. So very small and precise topic we're going to focus on, but this has been one of the inputs to drive more work on more than just clinical quality improvement, but also bringing in utilization and even drivers of cost and affordability. So more to come as we work to get data to supplement our robust clinical data.
Super, thank you. Then we also have another from Tony Robertson. Do you use a third party or a software system to receive that data from different EHRs?
So we do have a vendor that we use. Our system is actually something that we built with a vendor. So it's a proprietary program that we own and built. There certainly are standalone vendors out there that can potentially do similar things to what we built, but back when we built this new repository, we contracted with a vendor to have it built for us, and that's what we're using. So yes, but not a national off-the-shelf program that you could just grab.
Great. I think that's all our chatted questions. Folks can also unmute and jump in with questions if anybody has any.
And Lisa, I just unmuted everyone, so anyone can speak if they'd like to ask a question aloud.
So I'm just going to read the question from Robert Pierce. One challenge, or okay, from Robert?
Yes, I'm sorry, I missed that one. Go right ahead. Yes, thank you.
Okay. One challenge with overuse is knowing the difference between not using the intervention versus using it but failure to capture. It'd be helpful for me to hear a sort of a explanation of the question, I think.
Can you hear
Robert?
me?
Yes, perfect.
Well, what I'm getting at is in the case of interventions or activities where we're trying to reduce the utilization, how do you tell the difference between I saw the patient, I made a conscious decision not to do that intervention, which is not indicated, versus I did it, but there was a data capture problem, and then your registry or your organization to which you're reporting doesn't get that because of the lack of structured data or my failure to record it correctly in the EHR, for example.
Well, and physicians will get smart. You know, they'll use different codes. One of the things that we noticed was, you know, and I hope I'm addressing this, this disappearing denominator phenomena. They stopped using these bronchitis codes when we said specifically, these are the codes that we're measuring. So that might be getting at part of it. You do the best you can. Those are very real issues, and there's no question. I think what we were trying to do is look both at the individual provider level performance and the system level to see that our message is getting across and that we're seeing that improvement. But there's always ways, it seems like, to make sure that the data is not necessarily being captured adequately. It is an issue.
And this is Kelly. I would say one thing we saw from the grants with issues like that was, and this is not necessarily what everyone can do, but that people would do spot check chart audits. So take a small sample and see if there seems to be a problem of people not recording, doing something, or recording differently to try and get to some of those themes that were emerged. We saw that happen throughout the grantees.
Yeah, I would say that's that issue as a whole for all of our measures is something we're continually working with. I am frequently asked by members for a manual or some instructions on how they can validate data, and embedded in it is that exact issue where they're trying to monitor clinician behavior or determine what they're missing. And we do training and provide instructions on how you can validate, but there really is no substitute for actually double checking by opening that patient record yourself and reading notes, or going to the actual clinic visit and tracing that information. Our members, when they report data, sometimes the first trigger they have that something has gone wrong, whether it's technical or behavioral or otherwise, is they see a drop in the denominator. As Greg just mentioned, something changes. They were expecting to see more patients screened that month for something, and it takes that manual check. It is a continually moving target. Not that people are purposely necessarily changing where they're documenting, but things get upgraded, the programs change. So we encourage our members to continually look for variation in what's coming through and make sure you understand why. So if your patient population doubles or drops or you're improving, you should start to wonder why and make sure you have an explanation. Just accepting that you got better without really understanding why is not acceptable. And in general, this is the new world of people that work in quality improvement, that this is how you track down improvement. As you first start with validating the data you have. So it's an iterative and not perfect process, but something we spend a lot of time trying to make sure we understand the data that we're bringing forth. And unfortunately, it's never done because the next time you measure it, things have changed.
This is Lisa Letourneau. I'll jump in. Not seeing another. Oh, here's another one. Right. Nancy Edlin. Based on your experience, would you say you can recognize a set of attributes in a practice that make them more likely to adopt these practices? The cloak of goodness.
It's really amazing. You can walk into a room with the providers, and within a few minutes, you get a sense of whether or not you're going to achieve your desired outcomes. There's enthusiasm. There's a sense of just positivity, and the variation amongst clinics and even in the same health system is one of the things that I was really struck with. And it's not just in the performance in these measures, but it's in their internal culture. So answering the question around attributes, believe me, we actually studied where and how many years in practice they've been, and is there correlation with their anything about their training. Nothing else seemed to make sense, but the local culture is what seemed to trump everything.
I think we see that too at an organization level. I mean, Wisconsin's unique in terms of our collaboration compared to some states, although certainly there are others that are working in the same vein. But we often talk about the intrinsic motivation of membership in WCHQ, that we are very interested and open to moving into other states and have actively pursued that in some cases to spread our model. But there needs to be an intrinsic motivator, and I think that's true at the clinician level as well as the organization level, that if you don't want to see your data and know and be compared and benchmarked, it's a difficult case to make. We can provide data, which starts the conversation, and slowly that can provide improvement. But the members that we have, the clinicians that are engaged, seem to have this almost intangible motivation to share and improve. But the data, as Greg said, I think it's an important point to highlight. Being able to compare at the clinician level is really important. Most organizations follow a similar track in that they start by blinding the data internally, and then they unblind it. That track has been quite successful and can bring along even some of the reluctant participants, but it needs to be connected to support. I love how Greg ends with, make it easy to change. That's the support the organization needs to provide. So we think that there is a way to move people along that motivation track, but we do find culturally some organizations start out ahead of others. At least at WCHQ we see that, and if they're not there, it's a slower track to improvement.
And related to that, I was actually going to ask about the timing, and I apologize if you said this, I missed it, but you showed the one slide that had comparative outcomes by practice, and then the next one was by individual. And
yeah.
Did you say, what was the time spend? Like, did you do the practice one for some period of time and then go to individual, or did they follow rapidly?
Yeah. Well, I mean, each slide, there was a 2016 versus 2017 calendar year. Is how we compared on each one of those slides. Yeah, no, we were looking at and sharing that data at the physician level as well as at the clinical level, throughout that whole time frame. But we only shared individual unblinded data with the individuals at that site. We didn't go beyond it.
Yeah, and I think I was referring mostly to the track of general improvement that we see among our members. Frater Medical College, where Greg works, is definitely well down that path with Greg's leadership to being used to sharing data. It's not as much of a shock. The argument about it's not my patient, et cetera, is somewhat over at that point. So, but some of that work has to happen when organizations have never done it, and we definitely have members who have never done that and need help figuring out how to roll something like that out. It's typically not as scary as they thought if they have good, valid data, which is something we work really hard at. But the first time clinicians see their own data and see it in a setting where it's unblinded can provoke some discussion. Also, I think it's important that you do have both options, especially sometimes when the intervention is not clinician focused. So Greg highlighted overuse versus underuse. Frequently, we find that in the underuse categories, there's a team-based approach that can be important to closing that gap, as he highlighted. So in those cases, our members sometimes prefer to share it at a practice level with multiple clinicians, because the nurse or other staff may actually be the ones making the call or closing the gap. So these are just tools that organizations can use depending on the audience to help make the improvement.
Super. Well, thank you all. We are right at the end of the hour. Kelly, did you want to see anything about the survey link you put there?
Yeah, just quickly that there is some research that supported Dr. Blommel's assertion that it's culture, and there are 4 domains in there, one of them being access to transparent data being a major cultural factor of high-value care. But if you're interested in finding out some of the other domains that influence high-value care culture, you can click on that link.
Super. All right. Well, again, thank you so much, Gabrielle Rude and Greg Blommel, and all of you for joining the call and the great discussion. Kelly, I'll leave it to you.
Yes, I just want to echo those thanks both to our great speakers and for everyone joining today. Again, we've recorded this webinar. We'll be sharing it on Workplace. You can also email me. And if you have gotten onto the webinar and are not part of the Choosing Wisely Learning Network, please email Kate Carmody at the email listed on the slide. Thanks so much, everybody, and have a great day.
Take care.
Thank you. You too.
Okay.